Good luck.
Thanks. Good day, everyone, and welcome to today's webinar, Power Over Pain, Re-envisioning Chronic Pain to Improve Access and Connection. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador College of Social Workers. I will be your moderator for this continuing professional education session today. This webinar presentation will be approximately 60 to 70 minutes, followed by a question and answer period. During the presentation, I encourage you to type in your questions using the question mark icon at any time throughout the presentation, and I'll begin asking them at the end of the presentation. So I now want to introduce our speakers for the webinar today. Julie Dwyer is a PhD candidate, health psychology instructor, and pain scientist at Memorial University. She holds a Master of Science in Clinical Psychology and has been working at the Center for Pain and Disability Management with the NL Health Service since 2017. Julie recently took on a short-term project management position to create a provincial pain program. Dean Penny is the clinical lead at the Center for Pain and Disability Management with NL Health Services, where he has worked for the past 17 years. He has 29 years of experience as a social worker and has a Master of Social Work with a clinical specialization. He's registered with the Newfoundland Labrador College of Social Workers and has been involved with our registration committee for the past 12 years. Dean and Julie, I'm really looking forward to your presentation today, and I'm now going to turn the virtual podium over to you.
Thank you. Can everyone hear me and see me okay? So I want to start with an acknowledgement of the partners that have been involved in this project. If you look across the bottom there, this has really been a national collaborative project involving the Sick Kids Hospital in Toronto, Memorial University, where I'm based out of at the Behavioral Medicine Center, the Alberta Children's Hospital, the Women's College Hospital in Toronto, and the Ottawa Hospital. I want to begin with a land acknowledgement. I acknowledge that the lands on which Memorial University's campuses are situated are in the traditional territories of several diverse Indigenous groups. I acknowledge with respect these diverse histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. So Dean and I work together at the Center for Pain and Disability Management. He is our clinical lead here at the program, and we are the only interdisciplinary specialized tertiary chronic pain program in Newfoundland and Labrador. We've been around since the early 90s, 1990, so just over 30 years. So Dean will talk a little bit and introduce us to the concept of pain and chronic pain now.
So just to start off with the latest definition of pain. So the International Association of the Study of Pain came out in 2020 with kind of a new definition of pain, that it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. There's a couple of words there that are important, that it's not just a physical thing. It's not just about your leg that you hurt. It's an emotional response. That's a component of it. And also the concept of associated with actual or potential tissue damage. So there's a concept that is not just biomedical, that is biopsychosocial, and that's kind of how our how our program runs. And the latest definition came up with the concept that certain types of chronic pain are actually a disease unto itself, which is really important because it is a misunderstood experience for lots of people. So our pain system, our stress system, our response system is all the same system, and it's very much designed for survival, this kind of primitive brain stuff that keeps us safe. So it has a protective function and it runs all the time. And the intention of it is to, it's a warning system. Something happens, you touch a hot stove when you're a child and you never do it again. And it is, while it's universal, it's often subjective and stuff. So that part of it is all part of the overall experience of people living with chronic pain or pain in general. So there's a lot of misunderstandings, myths, misperceptions, whatever you want to call it out there about pain. It's not well understood, and I think it has a lot of um, issues that people who live with chronic pain have to deal with. So the belief that pain intensity is directly related to the extent of damage and dysfunction. Um, we'll talk in a minute about acute versus chronic pain, but this is the concept of, you hurt your foot, you go to the doctor, you get a bit of physio, and you get better. And that's kind of most people's perception. But the fact of the matter is that for many, that's not their path. Person with pain person has pain when there is a structural physical problem that needs to be fixed. And that's the path for some, but for many people who come to our program, that is not the path because there's actually a national thing for doctors called choosing wisely around the appropriate use of diagnostic imaging and stuff. And it's not considered a useful tool to assess the level of people's pain. So getting a bunch of x-rays or MRIs and you find something, but that might be, and one of their slides was about, if you x-ray like 50-year-old back, you're going to find degenerative changes, but some people might have pain, some people might not. So it's not a good indicator that way. When the problem is healed or fixed, the pain will stop. And that may be the pathway for a lot of people from an acute perspective, but certainly it's not the pathway for people with chronic pain. It's more complicated than that. And hurt does not equal harm. That's a big one for us here because people often have flare-ups and exacerbations of their pain experience. But, obviously your perception is if something hurts and there's more damage being done. But we teach people that for most things that happen when you're talking about a flare-up, what we use that term, then that's it hurts, but it's not further damage being done to your spinal column or your discs or whatever. So we talk a lot, about the difference between acute and chronic pain. So our healthcare system is really good at, you go to a doctor, you hurt yourself, and whatever. So acute pain is useful pain. It's with the protective mechanism of our response system that kind of helps people to kind of come with a linear pathway towards recovery. And, you, again, hurt your foot, see your doctor, get some physio, get better. And it can be explained easily. Like, this is what happened. We show this on your x-ray, and this is what we're going to do to treat it. And the goal is curing pain. And that tends to be around less than 3 months versus when we talk about chronic pain. It's a maladaptive response. So the protective mechanism of our pain response system is gone awry. So it's a faulty protection system. And part of it is that may not have clear connection to diagnosis or injury. Lots of people who come to us may have had an accident years ago or something, but we mostly get people well beyond the expected healing time. The average length of time that people have lived with chronic pain by the time they come to us is about 10 years. Pain continues beyond the expected healing time, recovery time. And there's all kinds of system changes, your stress response, your nervous system, immune system, endocrine, muscular. It impacts the whole system. And basically, if you flood your system with adrenaline and cortisol for years and years and years, then it's going to impact your whole system. So often people have other things that emerge as issues for them if they have chronic pain for a long period of time. And like I said, with the International Association of the Study of Pain, with their International Classification of Diseases 11, it addresses the concept that chronic pain is a disease, and that's kind of relatively new. And the goal on this is management, of course, and that's kind of, we are the Center for Pain and Disability Management, so that's our goal. So the latest World Health Organization's International Classification of Diseases 11 classifies 2 types of chronic pain, and chronic primary pain is characterized by persistent pain that is not better explained by another underlying condition. It's a diagnosis of exclusion, meaning that other potential causes of the pain have been ruled out, and the pain is considered a primary condition unto itself. Whereas chronic secondary pain, on the other hand, is associated with an underlying condition or injury. It is pain that persists long after the initial injury or condition has healed. This type of pain can be related to various medical conditions such as chronic arthritis, neuropathy, post-surgical pain. So a lot of people who come to us have had something happen, and chronic pain has developed because of that, or not because of that, but has developed after that. But there are people who develop chronic pain, and it slowly just develops over time with no necessary cause, if you want to use that term. So we at the Center for Pain and Disability Management operate from a biopsychosocial model, and we talk about things from a physical, behavioral, cognitive, emotional, and social changes that happen for people. So the biological, and that's the biomedical model, which most of our healthcare operates under. So that's physiology, genetics, biochemistry, and neurobiology. So we also take into account psychosocial factors. So from a psychological perspective, you're talking cognition and your thinking patterns, emotional factors, behavioral patterns, coping mechanisms. And certainly from a social, you know, perspective, the social determinants of health certainly impact people's ability to recover. So economic factors, social support, cultural context, environmental factors. And the interplay there, of course, is, trauma, adverse childhood events, um, health, illness, mood. So the point of it is that chronic pain is a very complicated issue, and it can't be just about getting the right treatment for your back or whatever, right? It's more. We have we have a doctor, nurse, psychology, social work, recreation specialist, physiotherapist, occupational therapist, dietitian, rec specialist. I'm not sure if I said that. So we have a big team. So pain represents a long-standing, prevalent, and costly public challenging, placing significant burden on individuals in the healthcare system. So that term "burden of care" is a I don't care for the term, but it is the term that is used to talk about that. So pain is the biggest one. So all other health concerns combined, pain is the most prevalent issue for why people present. So 78% of ER visits are about pain. Um, Certainly the population we serve have to be able to do a day program and have to be able to ability to be here all day for 5 weeks and all that sort of stuff. So not everyone can do that. So the concept of this health system's inability to effectively manage pain is directly linked to the opioid crises. So we don't really get many people who have a big issue with opioids at our program. That's not because they're not out there, but it's because their life is so complicated because of a bunch of factors, really, social determinants of health and all that sort of stuff, that they would never be able to maintain being in a day program for 5 weeks and stuff. So that level of, you're seeing a doctor and that's the only option you have, and you get prescribed opioids and all that sort of stuff. And some people with that system is the gateway into addictions issues and stuff. So managing the opioid crises, although I've been a social worker for 29 years, and I think we've been in opioid crisis for at least 25 of them. So just some stats: about 1 in 5 Canadians experience chronic pain, about 7.6 million Canadians estimated. So we're 1 in 5 nationally, and Newfoundland is 1 in 3. So it's even more common here. And just from a stats perspective, this is part of the Canadian Pain Task Force final report that came out in 2021. I was part of that. I was part of the external advisory panel of that task force. So costs more than cancer, heart disease, and HIV combined. Direct healthcare costs 15 to 17 billion. So that's like treatment, doctors, and all that sort of stuff. And indirect 43 billion national annually. And that's, the associated things like people are not working and all that sort of stuff. And there's no dollar value attached to people's quality of life, because most people who come to us, or certainly who live with chronic pain that's not managed well, certainly have quality of life issues. So this is an image called the downward spiral, and it's the physical, behavioral, cognitive, emotional, and social changes that happen for people as a chronic pain takes over. And it's an image we share with people on the first day of our program. And certainly things like work changes, negative focus, guilt, depression, anxiety, all of that sort of stuff. So, the comorbidities, or whatever language you want to use on that, is that it's not unusual for people who come here to have some level of depression and anxiety, whether or not that's big D or little d. Because, if you have an assault to your system for 24 hours a day for years and years and years, it's going to impact your ability to cope and all that sort of stuff. So this image is one that clients often comment on. It's like, "Oh my God, how did you know? This is me." Sometimes we have tears and all that sort of stuff. So it kind of encompasses the fact that chronic pain is not just what happened to your back or whatever. that it impacts everything. Sleep is certainly impacted, all of the stuff there. Family dynamics changes, relationships change, social activity changes, all of the emotions. People are so easily frustrated, and that causes them grief in regards to having relationships with people and stuff. So part of our work is we create what we call an upward spiral. So we're looking at trying to change that trajectory so that people have more control of their life and more control of their pain so that they can have better function and better quality of life. So from a healthcare perspective, obviously I just talked about the physical, behavioral, cognitive, emotional, and social changes. So it interferes with function that way. The multidimensional nature of pain requires intensive and collaborative interdisciplinary intervention using a biopsychosocial model. So research indicates, and it has for years, that the best treatment for someone who's living with chronic pain that their needs are not met by the acute care system is to do a program like ours and an interdisciplinary team and over a group-based intervention, because we talk about that with clients all the time, that you get all kinds of lovely information from the professionals, which is really important, but you also get to hear validating stories from the people sat next to you in the room, and that can be very validating and normalizing, because chronic pain can be a very isolating experience. People often feel that there's something wrong with them or something else is wrong with them. And again, the downward spiral kind of shows that it's all part and parcel of living with chronic pain that's not managed well. Despite advancement, pain remains undertreated in Canada. It's often um, it's not treated well, I guess, but I mean, depending on where you live and how small the community is, even your access to anything. Now, when COVID hit and we switched to virtual, that really increased our accessibility. So, because otherwise people would have to move to town, move to St. John's for 5 weeks in order to do our program. So, the ability for people in rural communities or in Labrador to be able to attend our program virtually really increased our capacity and our accessibility. Um, just as a point of note, that not most healthcare people, when they go through education in their professional bodies or whatever, they don't learn a lot about pain. I certainly didn't. Um, and veterinarians receive 5 times more pain education than physicians, which is an interesting stat when you look at it. I mean, they have to assess nonverbal, like you know cats and dogs and stuff. So their ability to assess pain, which is the biggest reason why people bring their animals, or people would attend, like the 78% people in Emerge are there for pain. Until recently, only 0.25 of health research was dedicated to pain. Um, our stats are skewed on our team because Julie is a PhD candidate, and we have our physiotherapist on the team has a doctorate, and she studied in the field of chronic pain incidence and prevalence in Newfoundland. So some more stuff about how the healthcare system is not quite well equipped to effectively deal with pain. So there's a lack of information and management strategies. People encounter stigma and other barriers. People report difficulty navigating pathways to care. Part of Julie's work with the province is the province has tasked the department or whoever with the task of trying to coordinate some pain services, because pain tends to be very much siloed around the province. So we're looking at hopefully getting to a point where there's some coordination of care there. Again, I said, like, people are often in pain about 10 years by the time they come to us. So they've done the physiotherapy and occupational therapy and massage therapy and might have been referred to neurology or whoever. And often people describe, I waited 2 years to see this doctor and he spent 2 minutes talking to me and that was it. So if it's not appropriate to the service, then we're looking at some coordination with that. Excuse me, healthcare professionals are inadequately trained to assess, diagnose, and treat pain and other concurrent issues like substance use. And that's universal. I mean, unless someone goes on to have more intensive training in that post their degree, then, unless it's your area of expertise, it's not part of the standard stuff. So wait times are all over the place. Ours is about 18 months. Sometimes people wait in Newfoundland for years to access intervention services like lidocaine or steroid injections. So average is 6 months, 21 to 24 months in Atlantic Canada, and some areas up to 4 years. So wait times are long. and people don't know what to do in the meantime. So limited pharmacological treatments like opioids are often the only pain treatment available, particularly in remote and rural areas, leading to over-reliance on opioid medication. And you can see from a doctor perspective, if someone is constantly coming to you looking for help, then you want to help. And if that's the only option, then that's kind of it's a hard one to have that conversation. And, sometimes people are on opioids for years and, the efficacy of them over time lessens, and it's all very complicated. So the need for a national strategy. In 2019, there was a Canadian Pain Task Force that was created, and I was part of the external advisory panel on that committee. So there were several reports written over the years, including the final one, which was in 2021. So the point of it was to collaborate with federal, provincial, and territorial governments, professional associations, and other pain stakeholders, including people with lived experience of chronic pain as well. And the point was to assess how chronic pain is addressed currently in Canada, review evidence to identify best and leading practices and areas for improvement, collaborate with key stakeholders to disseminate information related to best practices to facilitate their uptake across the country, and probably the ongoing implementation stuff into 2024. So when that chronic pain task force was finished, one of the things that was to come out of that was the creation of what Julie's going to talk about now in a minute. That came out of that task force. And now it's over to Julie.
Thanks, Dean. So Dean has identified the many reasons that pain is complicated to treat, the stigma, the barriers within the system, the understanding of that. So the Power Over Pain portal is an initiative that's been funded by Health Canada's Substance Use and Addictions program. And as I said, this is not just Memorial University here in Newfoundland that worked on this. We'll talk more about how many people were involved, but again, a really collaborative national project to create a platform, to create a tool so that people living with chronic pain, as well as healthcare providers, people that work with people living with chronic pain, had access to support, had access to education. So the Power Over Pain portal provides access that is free, it's flexible, it's responsive, and it can be individualized for each person. Because if we think back to that slide that Dean showed a little while ago, that biopsychosocial model, no two people have the same pain experience. Your lived experience, your medical history, your social, cultural context, all shape your symptomology and your quality of life. So Power Over Pain is in line with an approach to healthcare that we call stepped care. And stepped care is an approach that has been adopted widely across the country for the treatment of mental health conditions. So it's been endorsed by the Mental Health Commission of Canada, for example. And here in Newfoundland, in PEI, in Ontario, in several other provinces, we are now trying to adopt a stepped care model for chronic pain. I'm working on a project with several provinces where we're trying to create a sort of formalized national pain strategy built on stepped care. So stepped care is a resiliency-based stage approach to the delivery of health services that's grounded in recovery principles. So from a stepped care perspective, it provides access to the least intensive intervention that's tailored to the person's needs. So the person living with pain's preferences, their readiness to change, because you can give somebody all the resources and tools and counseling and medical interventions in the world, but if that person isn't willing to embrace that and work on that stuff, then it's not going to work for them. So this is really the framework that underlies the development of the Power Over Pain portal. So this Power Over Pain portal was years in the making. So as you can see here on the right, there's 9 steps. So in Newfoundland, we've adopted, and PEI also is moving to a circular model. But here we have it listed as kind of a staged model. You can see each one is numbered 1 to 9. So that comes from Peter Cornish, who first developed Step Care 2.0, as I said, for mental health. And it favors strength-based interventions and uses outcome monitoring to adjust treatments. We're continuously looking at people's mental health, physical health, etc., to adjust treatment. So the idea is that an individual is getting the right service at the right time that's appropriate for their specific pain needs. So this 9-step model, when we look at steps 1 through 5, so informational self-directed, interactive self-directed, peer support groups, workshops, which are live or via recording, for example, or online courses, and guided self-help, all of these 5 options can be addressed through the Power Over Pain portal. It's important to acknowledge from the perspective of Health Canada, from the perspective of the universities and hospitals that are listed here across the bottom of the slide, the shift in chronic pain treatment is that we consider it chronic pain and associated substance use and associated mental health. And what I mean by that, if you have somebody, so as Dean mentioned here at the CPDM, at our interdisciplinary program, on average, someone is living with chronic, persistent, debilitating pain for about 10 years before they come to see us. They're navigating the system, they're frustrated, they're isolated, they're becoming more and more depressed, more and more deconditioned. So the shift in the approach here is that we're no longer trying to figure out what's depression, what's substance use, what's chronic pain, because they're also intricately connected. And as an aside, the language that the Power Over Pain portal adopts is substance use health rather than substance abuse or addiction. And part of the reason is to reduce stigma. And the idea behind the concept of substance use health is that we all have substance use health that exists on a spectrum. Smoking, drinking, drugs, food, we all have our own unique relationship with substance use. So from the perspective of Power Over Pain, this is not a progressive model. Someone doesn't enter the health system at step 1 and work their way up to step 9. If they're in, acute crisis and they need case management, they need specialist consultation, well, they're starting right at the top, getting that service that they need then. So the idea is that we're not matching the system to the symptomology. The person living with pain is really empowered in their healthcare relationship with their doctor, with their provider, to really advocate for what they need and have a say in that. And as you can see, the engagement and the investment from a healthcare perspective, even the engagement and investment from the person living with pain, it increases the higher you go in that model. So the lower steps have more autonomy and less investment. So the Power Over Pain portal is an attempt to address some of the barriers that exist within pain care. So as part of my doctoral research here in Newfoundland at Memorial University, I have studied sort of what are the reasons people have such trouble accessing care. And they exist right across the system. There are many levels to this from a social ecological model. And there are some populations that are experiencing disproportionately more pain. So Indigenous communities, gender diverse people, people who are incarcerated, veterans, people who are unhoused, people who live with trauma, children. So these vulnerable populations are experiencing even more than that 1 in 5 statistic that we talked about earlier. So from a stepped care model and the way we've developed the Power Over Pain portal is that we're really trying to acknowledge the interconnectedness between people, community, and systems, regardless and inclusive of race, culture, religion, gender identity, ability, and sexual orientation. And as I said, Indigenous communities are a population that experience a lot more chronic pain. And part of that is directly related to the systemic trauma that historically has been experienced. So as an initiative with this Power Over Pain portal, we're supporting restorative practices that address these impacts of colonialism, racism, sexism, ableism, and many other forms of oppression that are found through all of our health systems right across Canada. Often people report, going to their doctor or going to the emergency room to seek treatment for their pain. They're in unbearable amounts of pain, and then they're labeled as drug seeking, for example. And some populations are getting more of this stigma than others. So we're really trying to acknowledge the importance of social inequities, the role of trauma in health, and not just our mental health, but also our substance use and our access to care. There's been some recent research since the Canadian Pain Task Force that was done in BC. BC is pretty progressive in a lot of their pain work. And they studied Indigenous populations who reported that even when they're in unbearable extreme pain, they're often unwilling to go to the hospital or to seek treatment because of some of these barriers and some of the stigma that they face within the health system. So as I said, historical practices and even some current harmful practices continue to exist within our health system, provincially, federally, and this fosters distrust in the medical system. It fosters further marginalization for many communities. So as I said, someone coming to our program has been living with pain, chronic pain, for 10 years. So they tend to have a distrust in the medical system. They don't feel seen. They don't feel like their experience is validated. They often are made to feel like their chronic pain isn't real or that it's all in their head because it wasn't coming up on a scan, for example. But as we know, since we changed this definition in 2020, that we don't need to see something on a scan for it to be chronic pain, to be that disease. So institutional changes are necessary to facilitate progress and to repair trust. So that's part of my, a little bit of my work with the Newfoundland Health Services, the provincial government, to kind of progressively address some of these things. So the step care model that I just showed, this framework for power over pain, encourages inclusion of different ways of knowing and healing. The idea here is that the healthcare relationship, so for example, you're all social workers probably, so it's not the person, your client, coming to see you and you're the social worker and you're giving them the healthcare. This is really a bi-directional relationship where that person is empowered to advocate for their own health and collaborate with you, the healthcare professional. So early intervention is very important when it comes to chronic pain. So as Dean mentioned earlier, we didn't know a lot about chronic pain for a long time. So as he said, only 0.25% of that budget, of the $1 billion Canadian Institute of Health Research budget, went to chronic pain. So that's the reason that we don't have a lot of information, because we weren't studying it. So now that we know more about it, we're trying to do better. And one of the things that we've learned is that these long wait times, so as Dean mentioned, some places in Canada, to receive specialized chronic pain care like we offer here at our program, the wait can be over 4 years, with vast areas of the country having no access at all. So these long wait times lead to health deteriorating. Your mental health is deteriorating, you're potentially depressed, you can't work, you're financially struggling, your mental health, your physical health, you're becoming deconditioned. Many of the clients we see even end up on sort of reverse day-night cycles where they're not really able to get out of bed very much. And again, this is given the nature of our health system in Canada, and we're fortunate to have public health care in many ways, but part of the other side of that coin is that there's limited capacity, there's limited resources, there's limited people, health professionals to do this work. So what happens when we have these long wait times? You're waiting to see a neurologist for 2 years or a surgeon, and your expectations are soaring. So I get an appointment 18 months from now to see a surgeon. I'm really hoping they're going to fix my back. My expectations over the next 2 years are, I'm putting all my eggs in this basket, that in 2 years, I'm going to see this physician, I'm going to see this specialist, and they're going to be able to fix my pain. And then 2 years pass, you see the doctor, and within just a minute or two, the physician, the specialist says, there's nothing I can do for you, I'm sorry. So again, this is then where health is further deteriorating, people have become further deconditioned. So the Power Over Pain portal is really trying to target that wait time area to provide early education, to provide early intervention. For folks living with pain, this is a tool for people experiencing mental health and substance use and chronic pain, but also it's a tool for clinicians. As Dean said, we're an interdisciplinary program, and that's really the gold standard for chronic pain treatment. but many people don't have the luxury of working with a team. Many people work on their own and are just the one discipline. So for example, as a social worker, kind of from that psychological, sociological perspective, you may not feel super confident with some of the physical medical aspects of talking about pain with your clients, but you can direct them to this resource and then have shared language to talk about that. You can educate yourselves on some of the aspects that maybe you're not too familiar with yourself. So there's lots of great resources within the Power Over Pain portal itself. So now I want to talk a little bit about the creation of this. As I said, it's funded by Health Canada. We got that funding a few years ago. So we have two separate portals. One is for youth. So as I said, youth are a vulnerable population when it comes to chronic pain. And 1 in 6 kids or youth that experience chronic pain, go on to live with that their whole lives. So that's impacting, again, social functioning, development, psychological functioning, physical health, etc. So our youth team, I'm very fortunate that I got to work and meet a lot of these folks in person over the past couple of years. So they're mostly based out of Calgary and Toronto. Jen Stinson, Melanie Knoll, Katie Burney, and our lived experience lead, Vina. And then our Power Over Pain portal for adults, Patricia Poulon, who's in Ottawa, Yad, who's also in Ottawa, and then Josh Rash, who's my PhD supervisor here at Memorial. And then we have Rachel based out of the University of Toronto, and Lynn and Natalie are our lived experience co-leads. So it's important to remember, sometimes I overlook how much work really went into the development of this. You can almost imagine that under each of these pictures, under each of these researchers, there's a full lab of people that were working on this behind the scenes. So a lot of resources went into this, and as Dean said, that came out of the Canadian Pain Task Force, an attempt to really rectify some of these barriers and systemic issues that we have witnessed around chronic pain. So the portal was developed with a lot of consultation through various different people. So we had a lot of lived experience, a lot of researchers, a lot of clinicians, a lot of policymakers involved, and right across the country, coast to coast, and several different committees involved in this. Collaborators, partners, we have a scientific advisory committee, EDI committee, knowledge mobilization, which is what this is right now, sharing this information, intervention providers, and of course our personal lived experience committees, which really are the most important piece of that. So there were many phases to the development of the Power Over Pain portal. If you are so interested, you can scan these QR codes to see some of the background research. But basically, we didn't kind of set out to say, okay, we're going to create this platform and here's what we think people with pain need. We asked. So we started in phase 1 by asking chronic pain healthcare providers, chronic pain healthcare directors and policymakers and people working in this field right across the country. We synthesized all that feedback. Then once we had that feedback, we did the same thing, except this time we asked people living with pain. We asked children, we asked adults, we asked family members. As someone living with pain, feeling, unseen by the system, what do you need? And they told us, and then we synthesized all that information. So then we put phase 1 and 2 together, and that's really phase 3, which is this knowledge translation, knowledge synthesis, scoping, review that existed. It says in progress, that's an old slide, it's done now. So we have now, through a lot of testing, getting feedback, this platform is now live and launched. You can go to poweroverpain.ca and access it. So this is what the interface looks like. So we have one in English, one in French. We're also working to develop Indigenous specific resources. So as you can see, there's one separate portal that are resources designed for adults, supports, one separate resource for children and for youth. And again, this has been tested with many, many people before we even launched it. But it's been live now for about a year, almost. So this is just a couple screenshots of what it looks like when you go on. So you can create an account. So one of the kind of implementation evidence-based perspectives on implementing something like this, is that we want to have continuous monitoring. We want to be able to know if this is working. Is this actually helping people? So you have an option, or your clients have an option, to create an account. So this is one of the biggest complaint areas that we have gotten over the past couple of years, is that people get reminder emails and they don't like getting those reminder emails from Power Over Pain portal. So you can go, if you choose to make an account, you can go into your settings and turn off email notifications so you don't get those. Signing up for an account gives you the ability to do self-assessment, to track progress, all the resources, etc. But you can still access most, if not all, of the resources and things available without an account. You just don't have access to that self-assessment and progress aspect of it. If you choose to sign up for an account, or your client does, this is kind of what the screen looks like. You can see that people are able to rate their pain intensity, their mood, how confident they feel in managing pain. So in the clinical world and the research world, we call that self-efficacy, and self-efficacy is probably one of the most important predictors of quality of life for people who are living with persistent pain, with mental health, with substance use, with activities of daily living it looks at, and it looks at sleep. As I said, sleep disturbance is huge for people that live with pain, often sometimes even getting to that reverse cycle concept. So there are some benefits to having this self-assessment that clients have told us, that people with lived experience have said it's beneficial, in the sense that they can take 6 months of this reports to their doctor and say, here's the data, this is not helping me. Here's how I can show you that I've been rating this for weeks and months, and I need my medication changed, or I need my counseling plan changed, or etc. So you can kind of gauge how you're doing over time. So there's 5 different steps of intervention within the Power Over Pain portal. So there is pain neuroscience education, loads of really amazing courses that are completely free. Pain U Online, Live Plan B, which came from Pain BC, which has now evolved into Pain Canada. There's videos, there's podcasts, really, really great pain education options, again, from that biopsychosocial perspective. So regardless of your discipline, you can go in and find something relevant to your field. The step 2 is virtual chronic pain self-management and health coaching. So that's being guided through some of this stuff. And we have things like the pain course, empowered management, acceptance and commitment therapy. And then in step 3, we get into that peer support, peer navigation piece, which is very beneficial. And people living with chronic pain get great amount and report great amounts of validation from hearing other people's experience. And again, as Dean said, it's one of the benefits of our program too, is being validated that your experience is real, even if maybe, over the past 10 years of your pain journey, nothing's ever shown up on a scan, or, it's an invisible illness. But having that peer navigation can be really helpful. And these can be live video calls, they can be phone calls, with all kinds of different options there. Then we get into step 4. So these are live interactive workshops. So there's a couple different ways that we offer these workshops. So we do orientation sessions. So you can sign up to actually take 45 minutes and learn how to use this platform, kind of go through it with a guide that'll kind of teach you how to use it best for your unique needs. We also do monthly pain-related workshops, and these are always on very relevant topics. So this past month, the topic was navigating the Canada Disability Tax Credit, tax benefit that sometimes many people with pain or chronic disease have trouble navigating some of these things. So again, this is not us as researchers saying, here are workshops on what we think you need. We're letting the people with pain tell us what they need, caregivers, and then trying our best to provide that. So these are live workshops that you can attend, or you can do them recorded, and again, completely free. The final kind of most intensive step within the interventions that are available through this platform is individual counseling. So this is obviously done virtually, but the individual counseling for adults is available through Homewood Health. And for children and youth living with pain, the individual counseling is provided by Kids Help Phone. So, if you have somebody who, depending, maybe it's private practice and they're running out of insurance, or they can't afford to keep coming, for example, again, this is a great resource. This is not meant to replace face-to-face care. It is not meant to replace the healthcare relationship between a person and a provider, but it's meant to really bridge that gap that exists within many of these barriers. So as you can see on the slide, the red words are the adult portal, and the blue words are for the youth portal. So as I said, this is actually a bit of an old presentation now. So there's a lot more children and youth resources than are on this slide now. So it's definitely worth taking a look if you work with kids and youth living with chronic pain. So there's all kinds of different resources. Just as an example, there's sleep and insomnia resources. There's mood specific resources. So again, mindfulness, for example, is, a gold standard approach to treating chronic pain. Mindfulness-based stress reduction was developed back in the 70s specifically to help people living with persistent pain. So all of these resources are available by category. You can also just on the search bar, search what you're interested in. There are neuroscience, understanding the relationship between our brain and pain, because again, as Dean alluded to earlier, sometimes we're in a lot of pain, but there's no harm being done. We're still able to exercise, we're still able to move, we're still able to engage with our lives, but because pain is so scary, and we all know that feeling of, oh my God, I hope this ends. Am I going to feel this way forever? That it can paralyze us. So these short courses and videos and things can really shift people's perspective and allow them to live a more meaningful life. So there's all kinds of different stuff about pain and substance use, cannabis, opioids, different podcasts, all kinds of movement and mindfulness resources available. So these are just some of the examples. There's way more on it. It sometimes feels a little bit like Netflix when you're kind of logging in, and it's a lot there. So you can search specifically by what you're interested in. You could search social work, for example. So implementation. So everything about this Power Over Pain portal was done in an evidence-based way, including the implementation process. So even designing this poster on the right-hand side took many, many months of collaborative work and feedback and integration. So all this to say, we have paper brochures and posters, electronic infographics, social media posts, and the intention of this information is so that it can be clinically integrated. So I will show you our partners on a later slide in a few minutes. But this Power Over Pain portal has been widely adopted by most provinces. So for example, here in Newfoundland, the Newfoundland Health Service has integrated it within primary care and tertiary care within provincial programs. And again, from that step care model, this is really taking care of those kind of first 5 to 6 steps. Community-based organizations, etc. So just to show you, if you are interested, my email, I think was on the, maybe it wasn't, it's jdwyer@mun.ca is my email. If you are interested in being sent any of these for your clinic or your organization, we have specific implementation tools designed for clients, so folks that are living with pain themselves. We also have specific implementation tools designed for healthcare providers. So those are just 2 examples. So in conclusion, access is a huge barrier for chronic pain. Many people are going, round and around, kind of getting lost in the system. This is, again, further fostering that mistrust and that kind of health deterioration. So this evidence-based virtual platform is really an attempt to minimize the impact of chronic pain, mental health, and substance use, particularly during that wait time that is sort of inevitably existing right across the country. So some aspects of universal pain care, this is not just in Canada, this is World Health Organization, International Association for the Study of Pain, globally pain is a burden. Even when we look at recent research on the top 10 most burdensome health conditions in the world, the top 10, chronic pain is 5 of them. different types of chronic pain diagnoses. So this is not just Canada that's having real struggles with this. This is really globally. We're realizing, wow, a lot of people are living with chronic pain. A lot of people with trauma are going on to develop chronic pain. A lot of people have trauma. We're shifting how we think about this as a society. So step care is a promising approach to ensure that folks with chronic pain receive timely access to the right resources and at the right time, with the ultimate goal to reduce disparities, to reduce inequity to pain care that unfortunately exists here in Canada. So as I said, the Power Over Pain portal is not meant to replace a healthcare provider. It's meant to complement a healthcare provider. And this type of presentation, not this exact one, but a version of this type of presentation that we're doing right now, I've done with many different associations, from family care practice teams and different types of physicians, massage therapy associations, occupational therapy, physiotherapy associations, chiropractor associations, to really help, multidisciplinary folks improve their shared language that we can use with our clients, that we're all on the same page. Because one of the single biggest predictor, and loads of research has consistently shown this over the past decade. There's been thousands of studies done that shows that catastrophizing, so rumination, magnification, for example, that is the single biggest predictor of quality of life for someone who is living with persistent and chronic pain. So sometimes what unfortunately happens is that a person might go see a pain specialist, a provider, a neurosurgeon, for example, or they might get their scan read. And that healthcare provider, unknowingly and perhaps unintentionally, might use a catastrophic language. Oh, the bulges in your disc your back is blown out, or, they might just say something kind of off the cuff, not really thinking about it. But the person living with pain holds on to that, becomes more fearful of living their lives, of making the pain worse, more deconditioned, more depressed, etc. So even just to get the country speaking the same language around what's appropriate to say, and in a way that we can work together to really improve chronic pain care. Because as Dean said earlier, this isn't a symptom of something else. For so long, we thought about pain, pain is a symptom. Oh, my arm hurts, therefore it's broke. But chronic pain, it's not a symptom. Chronic pain is the disease. And as Dean said, there's two different types. So again, this is the intention of this platform, is to really bridge that kind of wait time gap and to help us sort of speak the same language when it comes to chronic pain. So just to acknowledge the many people that have been involved in this. So extensive amounts of work have gone into this. So our youth team, we had co-principal investigators, co-investigators, knowledge users. So those are our lived experience folks leading the charge, really. Our youth collaborators. So these are some of our organizations and hospitals and different groups existing across the country. Maybe you see yours there, that have been involved in this and have helped us implement it and use it within their practice. From the adult perspective, so I work with the adult team, lots of people involved there. And then these are our adult collaborators. So again, many different organizations, different hospitals, different academic institutions and organizations have really worked together to bring all of the best pain resources and pain supports into sort of a one-stop shop. Anything you need to know about pain, you can find there. And it's always free. It's not one of these things where you have to sign up for an account, you get access to it for a little while, and then you got to pay a subscription. It's 100% free. It's 100% confidential. If you sign up for an account, or your client signs up for an account and they're inputting their self-assessment, that information is not going anywhere. It's actually getting deleted because it takes up so much space from our back end. So it's completely confidential. We've had questions in the past, does it go to insurance? Can people access that? No, hard no. So call to action to you fine folks as social workers right across the country. What can you do? How do you fit into this? Well, you can use it. You can recommend it. You can integrate it. You can contribute. And by contribute, I mean, if you go on and have a look and start using it and you find something that doesn't work or something you think is bad or something that doesn't jive with you, then you can tell us. There's an email on all of our information resources and on the website itself, specifically for receiving feedback. We're constantly reiterating this to make it kind of the best it can be. It's changed tremendously just in the past 6 months, for example. So that is kind of our presentation on this.
Wonderful. Excellent presentation. Thank you so much, Julie and Dean. Fabulous presentation. Lots of great information. So we have arrived at our question and answer period, and we have had several questions come in. And I encourage others, if you have questions, type them in the question mark widget. The first question we have is, have chronic pain programs across the country been made aware of this resource? And I know, Julie, you talked a little bit about the presentations you've been doing, but just specific to that question around chronic pain programs across the country, are they being updated and aware of this resource?
Yes, I would say every province is aware, and maybe in some provinces there's different levels of adoption of it. But this has kind of widely been made available and been made known. As I show the many people that are involved in this, these are people right across the country. Just a few weeks ago, we all went to Ottawa for the National Pain Congress, and Power Over Pain Portal was a recurring topic across many of the different pieces of that thing. So yes, people are widely aware. That's not to say that it is widely used in every province, some more than others.
Okay, no, thank you. It's great. Do you anticipate that the funding will remain in place for this initiative, and in terms of updates to the web, to the portal, and those kinds of things?
Yeah, so that's a great question. So we have a set amount of funding from Health Canada. But the positive news is that we have been guaranteed, so Sick Kids and another organization have stepped up and have agreed to continue to fund this if and when that Health Canada research money does run out. So it will continue to exist, which is really positive.
Mm-hmm. Yeah, wonderful. Thank you so much. Someone else just made a comment that the in terms of the website currently showing the counseling option as Wellness Together Canada, is there a plan to have another counseling platform added for people to be able to access counseling under the adult section of the platform?
Yeah, so that was an old screenshot. So as I said, I've been doing some version of this PowerPoint for 6 to 9 months now. So yeah, Wellness Together Canada was an initiative that came out of COVID, and the funding for that has been cut. So yes, Wellness Together Canada does not exist, but the counseling, I'm not sure if you saw the slide with the multi-steps, but we have Homewood Health doing the adult online counseling and Kids Health for the youth supports there.
Okay, excellent. Thank you. So we still have some more questions and we still have lots of time, so keep those questions coming in. Someone had a question and they were just curious if there are now stats available regarding if access has been improving and what specific needs have diverse groups asked for in accessing healthcare to support their pain.
So if there are no stats available regarding, so the stats we have on access, so if we think back to the slide that Dean said, 0.25% of the $1 billion Canadian Institute of Health research budget went to chronic pain. That's only in the past 5 to 10 years that's changed. So the most recent stats we have occurred as the result of this sort of shift and with the Canadian Pain Task Force. So no, basically access, there are no updated stats, but also the ongoing research teams are showing that unfortunately, the access piece is remaining consistently bad as of right now. And I mean, these conversations, this work, this webinar, these are all attempts to help address that, but it's not a quick fix. For the past, until recently, we have really focused on this really biomedical model. It's only been the past 50 years that we've started to integrate a biopsychosocial model within a Canadian healthcare perspective. So it's going to be we have to be patient with systemic change because it takes a long time.
Do you have a sense of numbers of users of the portal?
You can email me at jdwyer@mun.ca. I don't have that stat off the top, the correct stat off the top of my head, and I don't want to misquote it, but I can easily find it. So if that is something you're interested in, please send me an email and I can get you the right number.
Perfect, thank you. Does the portal, another question we have is, does the portal offer resources for allied health teams, specifically in facilitating groups?
There are resources for different types of disciplines that exist within allied health, but there aren't resources available specifically educating providers on how to facilitate groups. What I will say though, through Pain Canada, which previously was called Pain BC, there is a program called Making Sense of Pain. And Making Sense of Pain, there's funding available. So this is based out of BC still through Health Canada, but there's funding available that allied health teams across the country can access funding to be trained in this group, Making Sense of Pain, that they're then able to provide that in group format to their clients. So here in Newfoundland, our family care teams have received that funding, so they're able to offer it to clients living with pain. So I would recommend maybe going on, even Googling Making Sense of Pain, Pain Canada, and all the information is there, but you can apply for the funding so that your organization can implement that within your clinic or programming.
Mm-hmm. Okay, excellent. Maybe Julie and Dean, both of you might want to jump in on this question. But in terms of, power over pain, the commitment to mitigate the stigma, around addictions to opioids and those kinds of things. And the question is, how challenging has this been to your mission of promoting and working on the power over pain initiative?
Can you repeat that? Sorry.
Yeah, just around how, obviously the power over pain, that commitment to mitigate the stigma that addictions to opioids and pain related to that. And just the person's just wondering, how challenging has that been to your mission around the development of this particular initiative?
Yeah, it's been challenging in some ways, but the people who are really spearheading this work, as I said, are, again, the shift from the perspective of the Power Over Pain portal and from a step care perspective is that we're not trying to separate substance use and opioid use from the chronic pain diagnosis, from the mental health diagnosis. And there are specific, here in Atlantic, Canada, anyway, I can't speak to the rest of the country. I know that other types of similar organizations exist, but within the Atlantic provinces across Newfoundland, Nova Scotia, PEI, New Brunswick, we have what's called the Atlantic Pain Mentorship and Addictions Network. And that's an organization mostly predominantly ran by physicians, but it's open to all allied health, all different pain care providers, and that really targets the addiction and opioid piece from a chronic pain perspective. And I know that there are similar types of organizations across the country, but also the webinars sometimes through the Atlantic Pain Mentorship Network and Addictions are often posted online for public access anyway, so it might even just be something to look into if that's something you're interested in.
Mm-hmm. And Dean, did you have any comments related to that question?
No, I have very little to do with the power over pain. That's really Julie's thing. So we don't often get people who have opioid addictions as coming to our program. If that's their most primary concern, or if their mental health is their most primary concern, then we kind of have to deal with that before you come here. Certainly, we've had people whose goal is to reduce opioid use, and we assist in that with the titration and stuff. If that's the client, if it's the client's goal, it's our goal.
Mhm. Okay, wonderful. Thank you. Another question we've had is how this relates to migraines. Someone has a client, a teenager, who has very migraines, and testing has not revealed any concerns. And would this program be applicable and useful to someone who's experiencing migraines?
We've certainly had people who that migraine is their primary source of pain, and our program has been useful for them. But that's mostly about the biopsychosocial, dealing with stressors and all that sort of stuff. But primarily, and I mean, migraine often does not show any type of diagnostic imaging in regards to what that might be up there. There may be some things, but from a reduction in overall pain, it's more about, like, again, the biopsychosocial model. Unfortunately, migraine is probably, I'm not going to say we're the least effective, but I mean, of the people who come here, the pre-post pain levels. Now, certainly from a biopsychosocial, managing your day and your mind and reducing stressors and all that sort of stuff, we certainly talk about that in the big picture. But from a pain at the beginning versus pain at the end perspective, I don't think we have much. There's not a lot of difference. Is that true, Julie? Like from your stats point of view?
Yeah, that's absolutely true. Migraines, that's a great question. Migraines are tricky. Actually, all chronic pain diagnoses are very tricky, but migraine is one of the trickier ones. Again, given the nature of that, you're probably fine 17 days a month and everything is all good, but those days that you have the migraines, they're write-offs, for lack of a better term. So as Dean said, some of those kind of holistic biopsychosocial strategies that are taught are still relevant. So just thinking of a client that comes to mind that we've recently worked with, she's still having migraines, but she's able to go out for a walk when she has a migraine. She's able to have better communication with her kids and her partner when she has a migraine. She's able to get a little bit of work done. So I think an important, and Dean alluded to this, and I'll just repeat it, is that when we're talking about chronic pain, the goal is managing it. We're not necessarily, if someone comes in with a 7 out of 10 pain level, and they come here at the CPDM for 5 weeks, showing that our program is beneficial doesn't mean that they need to walk out with a 2 out of 7 pain level. They can still walk out with a 7 out of 7 pain level, or even an 8 out of 10 pain level, but they're more active. Their relationships are better. They're doing more. They're able to, get out of bed and do these different things. So the quality of life measures are really what we look at when we think of that. So the Power Pain Portal and the interdisciplinary program can certainly help people with migraine, and we've seen that ourselves, but it certainly is one of the trickier options given the nature of the migraine.
Mm-hmm. Okay, excellent. Thank you. There's still some questions coming in. We still have time, so we'll continue going through the questions. Person's wondering if the Canadian Armed Forces and/or Veterans Affairs Canada are aware and referring members and veterans to the portal program, from your knowledge of that.
Yep. Go ahead.
The Canadian Armed Forces is very aware of the work of this program. They have their own program about substance use, and so they're very much involved in that. And they were, I think, at one of the sessions we had someone from CAF as part of the discussion when we were part of the task force. So yes, I think they're very aware.
And Julie, you're nodding, so you're same thing.
Yeah. So in many ways, Veterans Affairs Canada and the Canadian Armed Forces are leading the charge on chronic pain. Well before the Canadian Pain Task Force started in 2019, Veterans Affairs Canada were the folks really looking into this and really trying to help people. And again, part of the reason is because veterans are one of these populations that are vulnerable and experience disproportionate amounts of chronic pain. So we said 1 in 5 Canadians, that is much, much higher in our veteran population. So the Center for Excellence, which is the Chronic Pain Center for Excellence, which is through VAC, Veterans Affairs Canada, They're very involved, very aware, and they've actually just recently this year created the first postdoc position, so postdoc fellow position, specifically for kind of implementing chronic pain stuff like this. So yeah, they're very aware and also very supportive.
Excellent. Okay, just a more practical question. Has the portal been reviewed by plain language specialists to look at language and understanding?
Yeah, every resource, every implementation tool, every brochure has gone through several levels of being vetted. So it is all accessible to, it's inclusive language.
Mm-hmm. Okay, excellent. Okay, we do have another question, I think, both for you, Julie and Dean. What do you feel might be some important next steps to encourage the language and culture around pain in order to shift the conversation to recognizing chronic pain as a chronic disease?
One of the things around chronic pain here in Newfoundland is like there's no champion of it. Like I know we have the eating disorders clinic and the Hope program and all that stuff, and Mr. Winters was central to the creation of that because of his advocacy. So when we were part of the task force, we talked about how do we get this to be part of a public discourse and stuff, and maybe is there some possibility of media campaigns to kind of address people's awareness and stuff, and doing things like this and the power over pain and making people aware, and even just reaching as many people as we can to kind of talk about the concept of chronic pain. And I know before I worked here, I really had very few conversations with my clients throughout the years about their pain level. I mean, they kind of call it there's several P's of people's like physical whatever, and that to ask the question. And I think one of the things around this thing today is to allow social workers for today to be able to have that conversation, because you don't ask a question you don't not prepared for the answer for. So, but if you are able to kind of ask people, because chronic pain is very common and often associated, so lots of people with trauma histories have chronic pain and stuff. Not that there's a causality by any means, but to be able to ask the question and feel that there are resources out there to support your ability to say, well, okay, there's this resource, and maybe you can watch a couple of these videos and maybe we can talk about it. I mean, it's not rocket science. I mean, you're probably aware of the kind of impact that stressors have on people's function. So including that in what one of the stressors might be, and increasing a comfort level across different professions to actually ask the question. And the Power Over Pain portal can offer you a resource.
Mhm. Julie, did you have anything that you wanted to add to that question?
No, I think Dean got that one good.
Excellent. So I just went down through the questions. I'm not seeing any other questions currently, but I do want to point out that the PDF of Dean and Julie's presentation is available in the resource section on the webinar platform, and also some videos and resources that both Julie and Dean have shared. So you can have a look at that. And there's also Dean, a number of years ago, did a presentation for us provincially on chronic pain and the Center for Chronic Pain and Disease Management, Disability Management, sorry. And that's available on our YouTube channel, but I've also included the link in the resource section, so you can hop on there and see more and watch that video as well. So it's all there at your disposal for you to use should you want to look at those resources on the platform. And I'm not seeing any other questions there currently. So Julie and Dean, I'll just give you a moment if there's any more concluding thoughts to wrap up the question and answer period that you might just want to share. Maybe you didn't have a chance to share earlier.
Just thanks for the opportunity to be able to do this on a national platform to increase social workers' knowledge around chronic pain, and the Power Over Pain portal to be a resource for you to be able to kind of have those conversations with people.
Mm-hmm. Yeah. And Julie?
No, I think Dean summed it up quite well. I think sometimes when we are talking about chronic pain, and in particular talking about some of these barriers, and as Dean mentioned, one of them is the education piece, not just for people living with pain, but for providers as well, and that it's a great tool to feel confident to have conversations that maybe you might have shied away from or thought, oh, they need to go to a pain specialist. But you can refer them to some of these, Warmer Mosley, who's a PhD clinical neuroscience professor at the University of South Australia, and he's really kind of globally leading the charge on sort of the brain-body chronic pain connection and the nervous system dysregulation and the super system and all of that. Because, and I've seen it on both sides, that the physical disciplines, so physios and OTs, for example, are really apprehensive to be like, oh, how are you feeling? Because they don't want to open that can of worms because they don't feel equipped to have it. And similarly, the psychosocial folks feel similarly about some of the physical strategies. So this gives all disciplines an opportunity to kind of approach the multidisciplinary areas from an evidence-based way by directing them to these specific resources and then being able to communicate using that shared language. The one caveat I would say is if you are recommending specific things to your clients, so, you know, a certain resource or a certain video or a certain course, I wouldn't recommend you recommend that to a client unless you have gone through it yourself, is one of the takeaways there. But no, that's all for me, I think.
And you get some CPE for doing it yourself.
That's right. Okay, well, on that note then, I do want to take this opportunity to thank Julie and Dean for facilitating this excellent webinar for us today and for sharing information not only about chronic pain, but the Power Over Pain initiative and portal. And I think regardless of your area of practice, you may be working with someone who could benefit from this resource and the information provided. And we hope that this has sparked your interest in learning more. And as Dean said, you can get some self-directed credits for learning more. So it's a win-win. So thank you, Julie and Dean, for taking time from your busy schedules to facilitate this session for us today and for making it national as well. It is truly appreciated. Just want to note that social workers in Newfoundland and Labrador can claim 1.5 required CPE credits for attending this webinar as per the NLCSW CPE policy. And social workers tuning in from across Canada can check on their CPE requirements in the jurisdictions in which they're registered. So again, while the webinar is finishing, the resource widget is available. You can go back in at any time to access those resources or download those resources, and they're available at any time for you. So as you begin to sign off, we do ask that you complete the evaluation form that will appear on your screen. As always, participant feedback from the webinars are greatly appreciated. So on that note, I want to thank everyone from attending from coast to coast. Again, a huge thank you to Julie and Dean for facilitating this webinar today. And we just hope that you enjoy the rest of your day. Thank you. Bye.
Thanks.
Bye.